Today, we're going to be taking a look at how policies, partnership, and practices can ensure that we scale up health systems and adapt them in a way to ensure that there's resilience and uninterrupted care, even in times of crisis and shocks like the ones we've seen over the last 2 years. On our panel today is Jayashree K. Iyer. She's the CEO of Access to Medicine Foundation. Leif Johansson, who is the chairman of the board of AstraZeneca. Chief Minister Jagan Mohan Reddy from Andhra Pradesh. Minister Reddy, if we're talking about the crisis that some countries are still in, talk to me about what happened in Andhra Pradesh and the interruptions to healthcare there and how you managed that.
COVID was one particular pandemic that nobody ever anticipated. At least we have not seen that kind of pandemic in our generation. So it was something that was unprecedented. And the entire healthcare system, which was present till then, had to be re-looked into in order to prevent something, in order to be a formidable force. If at all something like this were to reoccur, then I think this actually taught us quite a few lessons, especially moving on to the importance of preventive and curative care, and also making sure that the healthcare system is available to everybody, is accessible to everybody, and also making sure that it is affordable to everybody. So all these aspects were an eye-opener to all of us. And within the limits that we had, we did everything what a country could do or a state could do. We were more focusing on tracing, testing, and treating. Because, from my state's perspective, we are short on tertiary care. Because tertiary care, we were a newly formed state, and we do not have a tier 1 city like Hyderabad or Bangalore or Chennai, where private investment is huge coming into super specialty hospitals. So since we had that handicap with us, so we wanted to get into the early stage, detecting at the early stage. So we conducted almost 44 rounds of house-to-house survey. We had a robust system in place with a village secretariat at every village, a volunteer system for every 50 houses. We had 42,000 ASHA workers, also the volunteers dealing with health issues, be present. And all these factors put together, we initiated this process of house-to-house survey. And in this close to 2 years of this pandemic, we've conducted almost 44 rounds of house-to-house surveys. So that was one of the primary reasons as to why we could cut the mortality rate. Even though the country's mortality rate was 1.21%, our state's mortality rate was the lowest in the country, 0.63%. So that's one of the primary reasons.
So, Minister Reddy, you were speaking earlier on about the challenges that you faced in the context of a newly formed state and trying to respond to the pandemic. Just talk to me then about how do we future-proof health systems against those kind of pandemics that you've spoken about from a governance perspective as well.
As I said earlier, governments would have to be focusing on two things. One is preventive care, and the other is curative care. And looking at this from the lens of how to improve this health care, one would have to be talking about availability, accessibility of health care, and also affordability of health care. All these three would have to be moving in line. In order to do that, from my state's perspective as to how we have been wanting to move forward is, we've taken every 2,000 people, every population with every village with 2,000 population as a unit, and we're coming up with village clinics.
Okay.
And then we're taking up every 30,000 population as a unit, and classifying it as mandal, and where we're coming up with 2 PHCs, primary health centers. These primary health centers would have 4 doctors, 2 of the doctors present in each of the PHC center, and they would be given an ambulance, 104, and each of this doctor would be given their designated villages. So 5 villages or 4 villages, depending on the mandal size, to each of these doctors. And these doctors, every alternate day, would hop onto the ambulance and visit the village, and they would become the family doctor for that village. Very soon the doctors, because they've been designated only those 4 villages, so they would start to identify people by names, and they would use this village clinic as a hub. This village clinic primarily would be having an A&M, nursing graduate, mid-level health practitioner, and ASHA workers that we spoke about also reporting there. So that would take care of the preventive part. Now comes the curative part. The curative part would be dealing with the community, with district hospitals, the teaching hospitals, and the area hospitals and the teaching hospitals are going to play a very critical role there. So there we're coming up with every parliament taken as a unit, in order to ensure that there is equitable distribution of teaching hospitals. Because only when you establish teaching hospitals, you have postgraduate students actually coming up there. And only when you have postgraduate students doing their course there, and these teaching hospitals are connected to a hospital, a teaching hospital as well. So teaching college and teaching hospital together would become the tertiary care that we are looking for.
Okay.
As she rightly pointed out, this is a major concern. In fact, to address this, the country as such had, under the leadership of the Honorable Prime Minister, had launched a program by name Ayushman Bharat. It's a more or less a combination of, it's more like an insurance part where the state governments are also involved in settling the claims. The funds come from central government, but it deals with 1,000 procedures or so. That is not sufficient, it's inadequate. So in the state of Andhra Pradesh, we have widened that scope, and we have come up with our own insurance scheme. It's called YSR Arogyashri scheme. I named it after my father because that's the kind of priority that I give to that scheme. So I just want it to be remembered, and I want to do a good job out of it. So what we have done is we've scaled the number of procedures to 2,446. From 1,000 what the central government supports, we increased that to 2,446 procedures. And practically, we have distributed cards to 1.44 crore houses. And we've increased the limit for the eligibility of this card to income limit of 5 lakhs per annum. So anybody whose income is less than 5 lakhs per annum is eligible for this card. And 1.44 crores out of the total households of approximately 1.5 to 1.53 crores cards that households that we have, 1.44 crore cards are covered under this scheme. Okay. And the last 3 years, we've helped almost 25 lakh people get treatment free of cost here.